Ahlan biku. Today we're going to study the anterior triangle. It's about time, I think. Okay, the anterior triangle, the boundaries, the posterior border is the anterior border of the sternocleidomastoid muscle, and the medial border is the midline, and the superior border is the inferior border of the mandible. It's an upside down triangle opposite the posterior one, and of course it's full of muscles, so that's why it's subdivided into smaller triangles. Like, for example, this is the posterior belly of digastric, this is the anterior belly of digastric, and this is the border of the mandible. This is the digastric triangle. For example, between the two anterior bellies of both digastric muscles, there is the submental triangle. Between the superior belly of omohyoid, the upper part of the anterior border of the sternomastoid, and the digastric muscle, posterior belly, this is the carotid triangle. And below the hyoid bone, between the midline and the omohyoid and the hyoid and the lower border of the lower part of the anterior border of the sternocleidomastoid, is the muscular triangle. You see it's full of muscles. So these are the subdivisions. Don't learn them by heart. Just know your anatomy and you will be able to figure it out. The muscles in the anterior triangle are classified into suprahyoid muscles and infrahyoid muscles. As we mentioned before, the hyoid bone has no direct articulation with the bone, and it's totally connected to muscles above it and below it. The suprahyoid muscles, we have the digastric muscle, which has an anterior and posterior belly. We have the mylohyoid muscle, this one. It comes from the mylohyoid line and to the hyoid body. When you remove the mylohyoid, deep to it, you'll find the geniohyoid muscle, coming from the mental spines to the hyoid bone. So we have digastric, mylohyoid, geniohyoid, that's three, and a stylohyoid muscle on top, coming along the top of the posterior belly of digastric. It's called the stylohyoid muscle, to the sides of the lesser corneum body of the hyoid bone, from the styloid process, of course. You know, their names indicates their origins and insertions. Okay. Infrahyoid muscles, we have an omohyoid, which is two bellies, as we're classified as digastric. By the way, there is a digastric classification, the muscle that has two bellies. Omohyoid has a superior belly in the anterior triangle, inferior belly in the posterior triangle. And remember, we mentioned the omohyoid inferior belly as the muscle that subdivides the posterior triangle into supraclavicular and occipital. Remember that. Now here, this is the anterior belly, and when you go deeper, remove the sternomastoid. This is the omohyoid. See, superior, inferior belly. It comes from the scapula, just medial to the suprascapular notch, and makes an intermediate tendon that is fixed to the clavicle by a sling of the investing layer of the neck. Now, before we go through this, especially when we'll be talking about nerve supply, this is a very famous subject to be asked in exams, especially in multiple choice. Some of the muscles we'll be dealing with are derived from what's so-called the branchial arches, or the pharyngeal arches, branchial or pharyngeal arches. There are 6 arches on each side, but eventually number 5 disappears. So we will end up with 5 arches. 1, 2, 3, 4, 5, but named the first arch, the second arch, the third arch, the fourth arch, and the sixth arch. There is no fifth arch, it disappeared. Now, these arches are mesenchyme with a piece of cartilage in it, and an artery and a nerve, and lined interiorly by the endoderm and from the outside by ectoderm. The folds formed on the ectodermal sides are the clefts, while while these clefts opposed to the other side, to the inside, another cleft, but it's called pouch. So the pouch is endodermal while the cleft is ectodermal. Okay, now structures will rise from these arches. Every structure will rise from an arch will take its nerve and blood with it. So that's why it's essential to know the nerve supply of the muscle, to know whether it came from an arch or not, and if it did, from which arch. And essentially to know the arch, the embryological development of a muscle, to estimate its nerve supply. So the first arch, the nerve is in it is the fifth cranial nerve, 5. The second is the seventh cranial nerve. This is the trigeminal. This is the seventh, the facial. The third is the ninth cranial nerve, which is the glossopharyngeal. The fifth is vagus, but the superior laryngeal nerve, superior laryngeal branch of vagus. And the sixth is vagus too, but the recurrent laryngeal branch of it. So it's 5, 7, 9, 10, 10. 5, 7, 9, superior laryngeal and recurrent laryngeal. So any structure that arises from any individual arch will take its nerve supply from the corresponding cranial nerve. Okay, this is easy. You don't learn them by heart. It's very easy. 5, 7, 9, 10, 10, and that's it. Okay, now let's talk about the digastric muscle. Digastric muscle, it has 2 bellies, 2 embryological origin, and dual nerve supply. 2 bellies. The anterior belly comes from what's so-called the digastric notch on the inner side of the mandible, and the posterior belly comes from the deep digastric groove on the medial surface of the mastoid process. They both meet in an intermediate tendon that is hooked up, pinned down to the body of the hyoid by the stylohyoid insertion. This is the stylohyoid muscle. It splits and its fascia pins down the intermediate tendon of the digastric to the hyoid bone for the digastric to exert its function. Imagine if we fix the hyoid bone, the digastric will pull down the mandible. If we freed the hyoid bone and fix the mandible, both bellies will raise the hyoid bone and eventually raise the larynx with it. Okay? This is the action of the digastric. Now, the nerve supply of the posterior belly is from facial, while the nerve supply of the anterior belly is from nerve to mylohyoid, which is a branch of mandibular division of trigeminal. That's the 5th cranial nerve. So the anterior belly is derived from exactly the 1st branchial arch, while the posterior belly is derived from the 2nd branchial arch. See how many multiple choice questions is there about one muscle? That's why I usually stress on these points that you will encounter in exams. Okay, the stylohyoid comes from the back of the base of the styloid process and descends down to the sides of the lesser cornea and the body of the hyoid. It's on top of the posterior belly of digastric, and its tendon splits, insertion splits to pin down the intermediate tendon of the digastric muscle. Stylohyoid with the posterior belly of digastric is supplied by the facial nerve, so it is derived from the 2nd branchial arch. Now, omohyoid. We talked about omohyoid. It's the superior belly from the body of the hyoid bone, inferior border, and intermediate tendon, and the lower belly comes from the upper border of the scapula, medial to scapular notch, and meet by intermediate tendon. We saw it beneath the sternomastoid, pinned down to the clavicle by sling of fascia from the fascia of the neck, investing layer of the neck. But the nerve supply of this muscle is spinal origin, from the ansa cervicalis. So it's not derived from branchial arches. It's derived from regular somites, like any other muscle in the body. Now you know the trick in this area, in these kind of questions: the branchiomeric origin and the nerve supply. Of course, the omohyoid will depress the hyoid bone. Thyrohyoid muscle is a small muscle between the thyroid cartilage and the hyoid bone, and it's worthy of noting that it's pierced by an internal laryngeal nerve and the superior laryngeal artery. Internal laryngeal nerve branch from the supralaryngeal of the vagus, and superior laryngeal artery branch of superior thyroid. On their way to supply the larynx, they pierce the membrane and the muscle on top of it, which is the thyrohyoid muscle. It's from a line on the thyroid cartilage called the oblique line and goes to the inferior aspect of the hyoid bone. This is the thyrohyoid. It's supplied by C1 that comes via hypoglossal nerve. So although it looks like a branch from the hypoglossal nerve, but it does not belong to the hypoglossal nerve. It belongs to C1, that whenever the C1 filled hypoglossal nerve is going down from the skull, it gave it a twig that's carried out by the hypoglossal nerve and distributed to its destination. One of the destinations is the thyrohyoidus muscle. So it's not from branchial arches. Okay, a very important muscle, very, very, very important muscle, which is the mylohyoid. Now, there's a famous question in the oral section of anatomy. The doctor asks you, when you put your index finger in your mouth and the thumb from the outside opposite your index finger, what are you holding? Actually, you are holding the floor of the mouth. And through this lecture and the coming lecture, we will know more and more about the floor of the mouth. One of the essential muscles of the floor of the mouth is, actually it is the floor of the mouth, is the mylohyoid muscle. It comes from a line. See that? This is the inside of the mandible. Line called the mylohyoid line. It existed because of the pull of the mylohyoid on it. It descends and goes medially this way to insert itself in the upper border of the body and greater cornea of the body of the hyoid bone. See that? This is the mylohyoid. Of course, I told you that the mylohyoid is the floor of the mouth. Its nerve supply is from nerve to mylohyoid, that comes from inferior alveolar, that comes from mandibular division of the trigeminal nerve. So it's supplied by the fifth cranial nerve. So the mylohyoid is a derivative of the first branchial arch. See? It's easy. Okay. Now about the relations of the mylohyoid, and this is not easy. Now this is a coronal section here. This is the tongue, this is the mandible, and this is the mylohyoid muscle. You'll find deep to the mylohyoid another muscle that goes almost perpendicular upwards. It's the hypoglossal muscle. Outside the mylohyoid, which is inferior to or infralateral to mylohyoid, is superficial structures like the submandibular gland, like the facial artery with its relation to the submandibular gland on its way to the face, facial vein, skin fascia, platysma, cervical branch of facial nerve, and the anterior belly of digastric is superficial to the muscle, while deep structures, the deep part of the submandibular gland, the submandibular duct with the lingual nerve looping around the duct. We have the hypoglossal nerve and the submandibular ganglia in between, hanging from the lingual nerve. And veni comitantans, which are continuation of the sublingual vessels, sublingual veins coming from the tongue, are deep to the mylohyoid. And deeper you will find the hypoglossus, and deep to hypoglossus you will find the lingual vessels. So remember, the lingual vessels, the lingual artery I mean, is medial to hypoglossus, while the lingual nerve is lateral to hypoglossus. The hypoglossus between the two lingual structures. Okay? So don't confuse this. Now, again, superficial is the superficial part of the gland, the facial artery, the facial vein, cervical branch of facial nerve, and of course skin fascia platysma, and the anterior belly of digastric, the deep part of the gland with its duct and the nerve looping around the duct, submandibular ganglion, and the hypoglossal nerve with veni comitantans, which are continuation of the sublingual veins. And deeper and deeper, there is the hypoglossus and the lingual vessels. Okay? So don't forget this, please. So genohyoid, as we mentioned, and anterior belly of digastric are part of the floor of the mouth. Since they came in relation to the mylohyoid, so they are part of the floor of the mouth. But genohyoid from the inside of mylohyoid, while the digastric from the outside or the superficial to mylohyoid. So actually, these are the structures you will be grasping between your index and thumb fingers. See how many structures? It's lots and lots of structures there. It's a difficult question unless you understand your anatomy. It will be very easy. You don't have to learn all things by heart. Just use logic and know what's unique about a certain anatomical situation. You know what I mean? Like here, lingual and lingual with a muscle in between. These things will make you remember quickly. Okay. Other remarks. The geniohyoid and thyrohyoid muscles are supplied by C1 via hypoglossal. There's another question that you will encounter in many of the exam models for the USMLE or the MRCS. The sternohyoid muscle, which comes from the back of the sternoclavicular joint and goes to the inferior border of hyoid, this is the sternohyoid, is medial upwards to the sternothyroid while lateral downwards to the sternothyroid. See, the sternothyroids go up like an Arabic 7 and the sternohyoids go down like an Arabic 8. See that? So the sternohyoids are more medial upwards than downwards, and downwards the sternothyroids are more medial. And the sternothyroids, which come out of the back of the manubrium sterni and goes to the thyroid cartilage, is of a lower origin than the sternohyoid. You will find this question laterally. Which one is a lower origin, the sternothyroid or sternohyoid? Which one is medial downwards? Which one is medial upwards? Okay? And if you think about it, you will find that the sternothyroid and thyroid actually were one muscle and split by the oblique line of the thyroid cartilage. Okay? Okay. Nerve supply of the genohyoid and thyrohyoid muscles supplied by C1 via hypoglossal. Remember I told you about the C1 via hypoglossal destinations? 3 destinations. It forms the superior root of the ansa cervicalis and the nerve to thyrohyoid, and ends by supplying the genohyoid muscle. And that's it. The anterior belly of digastric and the mylohyoid are supplied by nerve to mylohyoid from the trigeminal. Posterior belly of digastric and stylohyoid by the facial. All the rest from the ansa cervicalis. Okay, ansa means loop. The cervical ansa, the cervical ansa. Its root value is C123. C1, the one we talked about that joined the hypoglossal nerve. Okay, see the hypoglossal nerve? This is the hypoglossal nerve. And this is C1 coming out of it, branch to the thyrohyoid muscle. Remember that? This is the C1 that will go down to form a loop with other branches. This is the superior root, or the descendants hypoglossy branch of the ansa cervicalis. See the superior root as it descends, it supplies the superior belly of omohyoid, then forms the loop with these nerves. See these two nerves, C2 and C3. They unite together and come either forward, either from the lateral surface of the internal jugular vein, or from the medial surface, or medial to the internal jugular vein, whatever, but they join the descending root and supply the rest of the muscles. This is the ansa cervicalis. Now I want you to notice something, that the ansa supplies the muscles from the lower part. See? So when you operate on this area, especially on the thyroid, or you're doing something with the trachea or the larynx, and you want to cut these muscles to clear the field, don't cut them down at the lower part. Cut them high up as much as possible to preserve their nerve supply so as not to get paralyzed. These are essential muscles for the movement of the larynx. Okay, this is a surgical note about these muscles. Okay, totally another subject, but in the same area. This is the thyroid gland. It's an endocrine gland. That means it has no duct, and to deliver its products, but it delivers products directly in blood. This is a definition of an endocrine gland. So it secretes hormones. The hormones secreted are dependent on trapping iodine from blood, and then it forms the hormones like triiodothyronine, T3, or tetraiodothyronine, that's T4. T3 is the more active form, and T4 actually is a kind of a storage form to provide to break down into T3 and exert and provide the body with more T3 stuff. Okay, and a special kind of cells between the follicles of the thyroid gland called the parafollicular C cells. These secrete another hormone, which is calcitonin. And calcitonin is the one opposing parathyroid hormone. The calcitonin promotes calcium ions entry into the bone. The calcium ions to enter the bone, not to come out of the bone. So it's osteoblastic. It builds the bone. Okay? This comes out from parafollicular C cells. This is a beautiful specimen from the Stanford University School of Medicine. This is an anterior view of the thyroid gland. This is a posterior view. Notice that the thyroid gland is composed of 2 lateral lobes. This is a lateral lobe. This is a lateral lobe, connected by an isthmus. And you'll find a 3rd lobe, actually. It's called the pyramidal lobe, that projects upward from the upper border of the isthmus and connected to a ligament here called the thyroglossal ligament. Actually, it was a duct before and obliterated. Thyroglossal ligament. You know why we have a thyroglossal ligament? Because the thyroid gland developed at the base of the tongue, below the foramen cecum of the tongue, and descended down, maintaining its connection with the tongue through the thyroglossal duct that gets longer and longer as long as the gland goes down. Okay, it drags it. And then eventually this duct will become obliterated and turns into a ligament that shares in the stability of the thyroid gland and connected to its pyramidal lobe. Now, the lateral lobes occupy from 1 to 6 tracheal rings, from the first, second, third, fourth through 6. And the isthmus is opposite the second, third, and fourth tracheal rings. This is not trivial information. This you will find in multiple choice questions. So I ask you before, please concentrate on the details I'm mentioning in the lectures, because trust me, and just try yourself. Try solving, going to question banks and see what happens. You will find many of the points in the lectures are as options of the multiple choice questions, the A, B, C, D, E options. This is the posterior view of the thyroid gland, and see those red, these red spots, rather dark brown, yellowish. These are the parathyroid glands. Note that the superior parathyroids are level with the upper border of the isthmus. They are not high up on the lateral lobe. See that? The highest one, see, this one, is upper border of the isthmus. So there are two pairs of parathyroid glands, two superior and two inferior. This is a posterior view of the same thyroid gland. It's a beautiful specimen. Now, since we know that thyroid gland traps iodine, we can trick the thyroid gland and administer radioactive isotope, iodine 131. It's harmless. It doesn't affect the body, but it's taken up by the thyroid gland. So you can take an X-ray and you will get a kind of these dotted figures. This is the thyroid scan, and this is how the thyroid looks like in a thyroid scan with a radioactive isotope iodine 131. Okay, we talked about the structure of the thyroid. Now, the whole thing, together with the parathyroids, together with the larynx, together with the cervical trachea and esophagus, are wrapped in the pretracheal fascia. Remember that, okay? Pretracheal fascia, the posterior layer of which, behind the pharynx, is called the buccopharyngeal fascia. If you skip studying, information will accumulate, and this is not a good situation. Okay. Regarding the relations of the thyroid, this is another beautiful specimen. See, this is the thyroid gland. This is the pyramidal lobe, and this is the ligament. See that? This is the ligament. These are the superior thyroid arteries supplying the gland and the thyroid veins. Well, we said it's all wrapped in pretracheal fascia together with the larynx and esophagus and trachea. Behind the isthmus, of course, is the trachea, the second, third, and fourth tracheal rings. Posterolateral to the gland, the carotid sheath with its contents, the internal jugular vein, the common carotid artery, and the vagus nerve. Excuse me. And posteromedial to the gland will be the trachea and esophagus with the recurrent laryngeal nerve in between. This is a very important relation. The recurrent laryngeal nerve is essential for the function of the larynx. So any injury to the recurrent laryngeal nerve in thyroidectomy will affect the production of voice, and maybe there are certain fatal conditions in which for injuries of the recurrent laryngeal nerve. We will study this with the with the larynx, inshallah. Sorry about that. I'm sorry. Injury to the recurrent laryngeal nerve will result in what's so called the hoarseness of voice. بحة صوت. The blood supply of the thyroid. We have the superior and inferior thyroid arteries. The superior thyroid artery is the first that comes out of the external carotid artery, descends down and divides into lateral and medial branches, sometimes called anterior and posterior branches. It supplies the upper part of the thyroid gland and may supply the superior thyroid, superior parathyroid. You never know. But actually, the one that supplies them is the inferior thyroid. It's not shown here, but you know now it's coming. It came from the thyrocervical trunk and made a loop. Why did it make a loop medially? Because the larynx is moving. It goes up. If the inferior thyroid was tight, it will get torn with the first swallow. Okay, so it has a loop. As well as the lingual artery, it has a loop in it, a slack for the movement of the structures it supplies. The inferior thyroid is closely related to the recurrent laryngeal nerve behind the thyroid. The superior thyroid is closely related to the external laryngeal branch of the superior laryngeal of the vagus. Actually, it descends with the superior thyroid and leaves it just when the superior thyroid enters the gland. So when you're in thyroidectomies, in any ectomy, when you remove an organ, you must devascularize the organ. So when you devascularize the thyroid gland, don't try to ligate the superior thyroid away from the gland. There is a very good chance, if it's not certain, that you ligate the external laryngeal nerve with it. So you will affect the cricothyroid muscle. But ligate the superior thyroid as close to the gland as possible when the external laryngeal leaves the superior thyroid. Now, it's the opposite with the inferior thyroid, because the inferior thyroid, as it gets closer to the gland, it intermingles with the recurrent laryngeal nerve. So try to ligate the inferior thyroid away as possible from the gland to devascularize it. And if you are, for example, want to split the thyroid to work on the trachea or larynx, remember to clamp very well the cut section to avoid what's so-called the thyroid storm. I mean, don't extensively injure the thyroid so as you don't get a rush of hormones in the blood, and it will put the patient into shock. Okay? The superior thyroid artery gives the superior laryngeal artery, supplies the larynx, pierces the thyrohyoid membrane. The inferior thyroid artery gives the inferior laryngeal that will accompany the recurrent laryngeal nerve and supply the larynx from below. Superior laryngeal, inferior laryngeal. The inferior thyroid also may give the ascending cervical branch on the side of the vertebrae. Now, there is another source of blood supply, but it's not common. The few arteries coming out of the arch of the aorta, the thyroid edema arteries, they are occasional to be there. We talked about the hemostasis. We talked about the thyroidectomies. Now, the venous drainage, superior thyroid vein to the internal jugular vein, middle thyroid vein to the internal jugular vein, right and left, of course, left to left side and right to right side. Look at the inferior thyroid veins. The left and right inferior thyroid, they both drain into the left brachiocephalic vein, and this is a very common question. See, why? Because the left brachiocephalic vein runs almost horizontally across the superior part of the mediastinum. So it takes both veins, no problem in that. But just don't forget, don't confuse it with the other two veins, the middle and superior thyroid veins. A lymph drainage to the deep cervical lymph nodes, which are the pretracheal, paratracheal, and retropharyngeal lymph nodes. Okay, the parathyroid glands, we talked about them. These the stained structures here, and we talked about their levels and their position. Their blood supply, mostly from the inferior thyroid, and they secrete the parathyroid hormone that promotes calcium ions to exit the bone. So it takes calcium outside the bone, so the bone will get brittle after the you take the calcium. It will be only a mass of organic tissue. That's it. Clinical aspect of this lecture. This is a case of hyperthyroidism, goiter. See, this is diffuse toxic goiter. This is the actual size of the enlarged. The goiter means enlargement of the gland, whatever may be the cause. Enlarged thyroid gland. Now, in hyperthyroidism, there's a slight stimulation of the retroorbital fat. So it increases in size, it divides and increases in size, pushes the eyeball forwards. And you know that this is abnormal because the upper eyelid is not touching or covering 1/6 of the iris. It should cover the upper part of the iris. But to show the eye white above the eye color, this is a clear state of exophthalmos. See? This is the swelling. This is most probably multinodular goiter. See that? Multinodules. On the opposite, hypothyroidism, it's called a case of mixed edema. You get this apathetic look, no expressions at all, and edema, especially peritibial and in the hands. See that? This is called a case of mixed edema. Now, this is a case of hyperparathyroidism. It produces what's so-called the brown tumors. See those vacuolations in the bone? Brown tumors. Because of more calcium is taken out of the bone. Now, sooner or later, this bone, this white, will become that thin. See? The bone will be depleted from calcium. Now, this is apparently swelling in the mid-neck high up. It's diagnosed as thyroglossal cyst, but when you get a mass in the middle like that, you ask the patient to swallow. If the mass went up, so it's definitely related to the larynx or a structure on the larynx, that is the thyroid. If it didn't, so it's not related to these structures. Now, suppose that it went up. Now ask the patient to protrude the tongue, or you pull it with a piece of tissue or gauze. You pull the tongue. If you saw the mass goes up with the pull, this means that it's most probably a thyroglossal cyst. That is, remember when we talked about the thyroglossal duct and it turned into a ligament, got obliterated and turned into a ligament? Part of it doesn't. So mucus starts to accumulate inside it and forms a cyst. This is a thyroglossal cyst, and this is how you diagnose it. I think that's it for this lecture, and thank you for watching.